He is going to be running a little late, so he sends his regrets. Normally, when we have some opening statements, obviously allow the chair and the chair of the other house to make one. Maybe what I may do, I'll ask him if he wants to, we'll kind of interrupt, and if he wants to say a few words. But again, I appreciate everybody joining us today for the hearing on the hospital fee initiative, which, as we all know, will be voted on November 2016 ballot. We're here to fulfill the requirement of Elections Code Section 9034, which requires a joint public hearing on the subject of an initiative measure. We will hear an overview on the measure from the Legislative Analyst's Office. The LAO is required to prepare an impartial analysis of the voter pamphlet describing the measure and a physical analysis showing the amount of any increase or decrease in revenues or costs to state or local governments. We will then hear from the Department of Healthcare Services on how the initiative will affect the current hospital quality assurance fee and the impact of the recently released federal managed care regulations on the hospital fee program itself. We will then hear from the proponents and opponents of the measure. What we're going to do is we're going to allow a maximum of 20 minutes for each side. We'll then take public comment on the measure. This is a joint hearing, as I said, with the Assembly Health Committee, and I'd like to see if there's any other members that are here that would like to make any comments at all. None? Okay. Senator Manning, any comments? Okay. Welcome, everybody. We're going to go ahead and start off with the initiative overview. We have Amber DG, Physical and Policy Analyst, and Mark Newton, Deputy Legislative Analyst, Legislative Analyst's Office. If you can come up. Good afternoon, and thank you for being here.
Good afternoon. Thank you, Mr. Chair and members. I'm Amber DG with the Legislative Analyst's Office. This is my colleague Mark Newton, who's the Deputy Director of our Health and Human Services section. Throughout my remarks, I'll be referring to a handout which you should have received in your packet. I'll be providing an overview of the hospital fee measure, including our analysis of the fiscal effects. This analysis represents our analysis thus far to date. We're currently in the process of preparing our analysis for the statewide voter guide, and as new information becomes available, we'll continue to refine our analysis going forward. Turning to page 2 of the handout, I'll provide a high-level summary of the measure. Under current state law, a fee is assessed on most private hospitals called the Hospital Quality Assurance Fee. The revenue from this fee is mostly used to pay for services in Medi-Cal, and under current law, this fee will sunset on January 1st, 2017. The measure would make this fee permanent. It would also generally make it harder for the legislature to make changes to the fee. Before I go into more details on the measure, I'll provide some background on Medi-Cal and on the Hospital Quality Assurance Fee. So turning to page 3 of the handout. Medi-Cal is California's Medicaid program. It provides health care benefits to over 13 million low-income Californians. In 2015-16, the total budget for Medi-Cal is roughly $95 billion, of which about $24 billion is general fund. And the costs of Medi-Cal are generally shared between the state and the federal government. California's public and private hospitals provide healthcare services to Californians, including those enrolled in Medi-Cal. The public hospitals are owned and operated by public entities, such as counties, and the private hospitals are owned and operated by private entities, and these hospitals may be for-profit or non-profit. The Hospital Quality Assurance Fee is charged to most private hospitals. It's been collected since 2009, and as I mentioned, it will sunset under current law on January 1st, 2017. Turning to page 4 of the handout. The fee results in state savings because 24% of the fee revenue is used as a general fund offset in the Medi-Cal program. In 2015-16, the fee is estimated to result in general fund savings of about $850 million. The fee also creates a net benefit for the hospital industry. Most of the remaining fee revenue that's not used for the general fund offset is used to provide payment increases to hospitals for the provision of Medi-Cal healthcare services. These payments flowing through Medi-Cal to hospitals also leverage federal funding because the costs of Medi-Cal are shared by the state and federal government. This leveraging of federal funds results in a net benefit to hospitals. So the hospital industry as a whole is made whole for the fee that they're charged, and then in addition to this, they see a net benefit. In 1516, the net benefit to the hospital industry is estimated to be $3.5 billion. Any extension of the fee, whether approved by the legislature or by the voters, would require approval from the federal government. This is necessary because the fee falls under federal law as a health care-related tax. And because the fee revenue is used to draw down federal funds for the Medicaid program, it's necessary to obtain federal approval. Turning to page 5 of the handout, I'll now go into more details on the measure. The measure would make the fee permanent. It also amends the conditions that would trigger an automatic end to the fee. For example, it adds the condition that if the legislature did not appropriate the fee revenues within a specified time frame, the fee would automatically end. Also consistent with current state law, the measure includes other conditions that would trigger an automatic end to the fee. For example, the fee would automatically end if federal approval was not received. The measure also makes it harder for the legislature to end the fee. Under current law, the legislature may end the fee with a majority vote. Under the measure, a 2/3 vote of both houses would be required to end the fee. The measure also only allows the legislature to make changes to the statute implementing the fee under certain conditions. There are 2 conditions that must be met. First, there's a 2/3 vote requirement of both houses of the legislature in order to pass the changes. Second, the legislature may only make changes for certain reasons without needing to go back to the voters for approval of the changes. So the legislature can make changes for 2 reasons, either 1, to obtain federal approval, or 2, to modify the methodology used to determine the level of the fee or the payments made to hospitals using the fee revenue. Changes outside of this scope would require going back to the voters for approval, which is, of course, different from current law where the legislature does not need to go to the voters for approval of any changes to the fee. Finally, the measure includes a constitutional amendment which exempts the proceeds of the fee and any interest earned on such proceeds from the Proposition 98 calculation. Turning to page 7 of the handout, I'll conclude with our analysis of the fiscal effects of the measure. The measure would result in savings to state and local governments. The exact magnitude of these savings is somewhat uncertain as a result of a recently released federal rule that governs part of Medicaid. So I'll start by providing our estimates of the savings, assuming that no changes were necessary to the fee as a result of this new rule, and then I'll turn to explain the potential implications of the rule. Assuming no changes are necessary to the fee, in the first full year of implementation, the measure would save the state about $1 billion general fund. I had mentioned earlier that in 1516, the savings from the fee was about $850 million general fund. This increase from $850 million to $1 billion is not a result of any particular impact of the measure, but rather is a result of the year-over-year growth that's seen in the fee revenue and therefore the general fund benefit from the fee, and we're assuming that that growth continues going forward. The measure would also result in increased funding for state and local governments through funding to public hospitals. In the first full year of implementation of the fee, public hospitals would receive about $300 million as a result of the fee. Finally, I'll turn to the potential effects of this new federal rule. In April 2016, the federal government finalized a rule that governs Medi-Cal managed care. This could result in changes being required to the fee because some of the fee revenue that's used to provide increased payments to hospitals flows through Medi-Cal managed care plans to the hospitals. So the way these payments flow through managed care plans needs to comply with these new regulations from the federal government. Because the regulations were released so recently, the Department of Healthcare Services is still working to understand exactly what changes may be necessary to comply with the regulations. And given that we don't know what these changes look like yet, the impact to the fiscal effects of the measure is uncertain. The impact could be in a positive direction, resulting in larger savings to the general fund and a larger benefit to the hospital industry, or it could be in a negative direction, resulting in a lower amount of savings to the general fund and a lower benefit to the hospital industry. So that's all of our remarks, and I'm happy to take any questions.
Thank you. Before we ask any of the members any questions, the chairman of the Assembly Health Committee is here. I'd like to give him the opportunity to see if he has any comments he'd like to say.
Thank you, Senator Hernandez. I apologize for being a little bit tardy. I just want to welcome speakers, the proponents, the opponents of the initiative. Obviously, we're here to provide a neutral and informational summary of the initiative and give people an opportunity to weigh in. So I look forward to the discussion. And once again, thank you for being here. My apologies for being a little tardy.
No problem. Any questions, any of the members? We'll go with Senator Roth, then Senator Monning, then Senator Pan.
So just so I'm clear, if this fee goes away, the initiative doesn't pass, it's about a $1.3 billion hit to the general fund?
It's about a $1 billion loss to the general fund, at least according to our estimates.
Plus the $300 million to the public hospital.
Correct, plus the $300 million.
So about if we cover that, about $1.3 billion.
If that were to be backfilled by general fund.
And if the general fund budget can't stand that hit, then I guess it results in a reduction of largely Medi-Cal services.
I think it would result in just a reduction of this payment increase that goes to hospitals for the provision of Medi-Cal services. And then the Department of Healthcare Services, I think, would have to work out exactly how that would play out.
So somebody's not going to get paid.
Or potentially just paid less than what they are currently.
And then, of course, that doesn't take into account, I gather, you were talking about net benefits to hospitals in general of about $3.5 billion. So there would be some additional impact to the hospital structure in the state in terms of reduction in overall revenue.
That's correct. The hospital industry as a whole would lose the current benefit they receive in 15-16. That's about $3.5 billion.
Thank you. Thank you, Mr. Chair.
Senator Monning.
Thank you, Mr. Chair and co-chairs for convening this. Can you help me understand how the fee is calculated? How is it assessed hospital by hospital? What is the fee placed upon? Is it a percentage of charges? Can you tell me how it's assessed?
The fee is charged on each inpatient bed day. The exact rate of the fee varies depending on whether it's a Medi-Cal bed day or it's a bed day paid by a private payer.
So depending on the size of the hospital and the number of bed days, it will vary hospital to hospital.
That is correct.
If the measure as proposed is not passed by the voters, is the legislature still able to continue it by a vote of the legislature?
Yes, the legislature can extend the fee through a two-thirds vote. The extending the fee does not require going to the voters.
If the measure, I think, so you answer my question, if it's defeated at the polling place, the legislature could continue it or modify it, but it would require a two-thirds. And it's currently set to expire when? January
1st, 2017. Although we would note that a one-year extension of the fee has been considered through the budget process. If that were to happen, the sunset date would be pushed out to January 1st, 2018.
So that is an option available through the budget. But within the budget, it would also take a two-thirds vote?
I believe that's correct. Take a two-thirds vote because it is a tax.
Right. Thank you.
Thank you. Senator Pan.
Oh, thank you. Thank you so much for your presentation. And just to clarify, because one of the issues as we were talking about Medi-Cal and other forms of also drawing out federal matching money, the funds, given the current mechanism, you said while the hospital industry as a whole would benefit, individual hospitals, some may actually get more, but some may actually end up paying more into it than they would get back from Medi-Cal. Assuming this is presumably that because they don't take as many Medi-Cal patients. Is that true?
That's correct. There are a small number of hospitals in 15-16. I think the number is about 9 or 10 hospitals who are not made whole.
Okay, so we just want to recognize that, well, one can argue that the industry as a whole would benefit, that actually what really matters hospital by hospital. There are some who will benefit, there's others who will not, but yet the industry itself as a whole is supporting this, even though some of their members may actually not financially, well, actually even be paying into more than they're going to get back, correct?
That's my understanding.
Okay, thank you.
Thank you. Any other questions from the members? A couple questions. I know you were talking about the initiative in order to change it through the legislature. A two-thirds vote. You had 2 points, obtain federal approval. I know what the other one, but can you go over the second point again? Just
Yes. The legislature may also, under the measure, make changes to the statute implementing the fee in order to modify the methodology used to determine the level of the fee, and also the methodology used to determine the level of payments that go to hospitals using the fee revenue.
okay. You know, I know that, like the MCO, there's going to be winners and some losers, and Senator Pan kind of touched upon it. There's a few hospitals that don't make themselves whole. And what was that number again? Was that 11, you said, 11 or 12?
I think it's 9 hospitals in one hospital system that are not made fully whole.
Okay. All right. Yes, Assemblymember Waldron?
Sorry, I just came up with a question. Thank you, Mr. Chairman. The measure also would amend the Constitution to clarify that the monies would not be subject to Proposition 98. Is the fee, the way it's set up now, currently exempt from that, or?
Yes, the fee revenue is currently not included in the Proposition 98 calculation, and this would just make that exemption part of the Constitution.
Yes, Senator Roth?
Thank you, Mr. Chair. Just a clarification. On the hospitals that are not made whole, why is that? Is that because they don't take, is that payer mix issue? They don't take very many Medi-Cal patients?
We would have to look into the details of that more closely, but because the fee revenue that's used to pay hospitals flows through Medi-Cal, it would make sense that it's hospitals that aren't treating a lot of Medi-Cal patients. But we could double check on that.
I was just curious. That's what I thought. Thank you, Mr. Chair.
Okay, thank you. Seeing no other questions, thank you for your time. We're going to now move on to item number 3, Department of Healthcare Services, Mary Cantwell, Chief Deputy Director, Healthcare Programs, Department of Healthcare Services. Good afternoon, young lady. How are you?
I'm all right, thank you. Mary Campbell, Department of Healthcare Services. So I was asked to address 2 specific questions regarding the initiative. The first question being, how would the initiative impact the hospital fee program and associated payments as it exists today? So with respect to that, the fee statute that was enacted in 2013 was drafted in a way that envisioned a permanent program. And so it provides the department the authority to develop future fee programs consistent with the statute. So if the initiative passes, what it does is remove the sunset provisions that would end the fee program, as the LAO mentioned, at the end of this year. And then the department would be able to move forward with future fee programs similar to the ones that we have today, where we have the flexibility to set the fee amounts and the payment amounts as provided in the statute. So this would let the fee program continue and continue the payments to the hospitals as well as the state general fund savings. The second issue I was asked to talk about is the impact of the recently finalized managed care regulations. First, just to be very clear, the regulations don't address the issues of provider taxes or fees as the source of non-federal share. They really are looking at issues of how you can direct plans to pay providers. So the area of regulations that we were concerned about was this issue of whether states could direct plans on how they pay providers, whether they're hospitals or any other type of providers. The final regulation text was changed from the original draft. And we think those changes were useful for California in being able to move forward with the types of programs that we have today. So while, as the LAO mentioned, we are still fully analyzing the regulations, we do note that those changes do now permit states to direct payments to classes of providers, so could be hospitals, certain types of hospitals, et cetera, under certain specified conditions. So that we could use the use of minimum fee schedules, specified percentage or dollar increases, or targeted value-based payments. So given those changes, our initial understanding is that, we do think there are paths forward where we could develop a fee program and be able to continue the program similar to how we have it today. as I noted earlier, the statute already has flexibilities for the department in developing future fee programs, so we believe that there are likely ways to make it work under the current statute. So if the initiative did remove the sunset provision, we do think the statute as currently drafted would enable us to continue to move forward even under the final regulations. So with that, I'm happy to take any questions.
Thank you. Any questions from any of the members? Yeah, Senator Pan.
Thank you so very much for that explanation. I just want to clarify. I have a question because right now, with the current hospital quality assurance fee, I mean, we have with Medi-Cal managed care, so you could either get it back through fee for service, but now with the fact that we've moved a lot of Medi-Cal into managed care, that I guess it would come back through the managed care portion. And my understanding is there's some disagreement with the feds on the methodology for the managed care portion in terms of the federal matching funds. Can you just tell me what the situation is for the current hospital fee and the managed and the federal match regarding the managed care piece coming back?
Yeah, so we do currently do it in both fee-for-service and managed care. The federal government, in issuing the regulations, really wanted states to move away from what they call pass-through arrangements, where it's, if we put in $2 billion into the rates, that we tell the plans exactly how to pass through that direct $2 billion. Their feeling being that that's not really tied to utilization of services, if it's just about a dollar amount. And so what they've done with this final regulation is still allow states to direct plans on how to pay and even pay increases, but they want to see that tied to utilization and not just sort of lump sum dollar amounts. So that's the sort of the difference that would sort of, today we build it into the rates and we say, okay, there's $2 billion here, pass it all through. Under the new regulations, we would instead be looking at some of these options that are afforded under the new regulations, where we would say you could do a particular dollar amount per inpatient day that the plans would have to pay. So it's not that different, but from their perspective, I think it's more of a link to the actual utilization occurring and not just some lump sum dollar amount.
So in terms of the current status of the federal match, is that starting to come through, or are we?
Yeah. So we had it for, so we've always done it. This will be the other change likely under the regulations. We've always done the hospital fee through the managed care plans on a retroactive basis. Okay. So we submitted the rates for the calendar year 14 year, and just quite honestly, generally with managed care rates today, because of the new processes at CMS, they're taking a lot longer. They're not questioning whether we can do it. It's just the length of time it takes to do it. So we've had some of the managed care payments flow, but some of them haven't yet. Okay. And
because I understand that there's been a while where it's been piling up while
yes.
we're trying to sort this out. Is that going to, are we going to have any problems going back in time to get that money?
No, we're confident that we'll get it. It really is. CMS has changed their process in rate approvals, so they're taking up to 9 to 12 months to approve our rates, which is really the problem. But it's not about the rates being problematic themselves.
And how much money is hung up?
I don't know that off the top of my head, but it's not insignificant. It's probably in the billions. Okay. Yeah.
So good chunk of money that
yes.
California should be getting back.
Yes.
Okay. Thank you.
Sure.
Thank you. Any other questions? Any of the members? Seeing none. Thank you very much. Okay, we're going to move on to item number 4, proponents. We have a list here of Ann McLeod, Senior Vice President, Health Policy and Innovation, California Hospital Association, John Ruffle, President and CEO of White Memorial Medical Center, Los Angeles, Christopher Manson, Regional Director, Northern California Government Relations, St. Joseph's Health, Eduardo Martinez, Associate Director, California Medical Association, Cesar Diaz, Legislative Director, State Building and Construction Trades of California. Good afternoon and welcome.
Thank you. Good afternoon, chairs and members of the committees. For those of you that don't know me, my name is Ann McLeod. I'm the Senior Vice President for Health Policy and Innovation at the California Hospital Association. CHA represents the interests of all hospitals in California, including public, private, teaching, safety net, rural, urban, and many others, such as children's hospitals and psychiatric facilities. I've been with CHA for 9 years, And for 15 years prior to that, I served as the chief financial officer for several hospitals and health systems throughout the state. I know firsthand that no hospital in California receives what they should be paid from the Medi-Cal program. And I've seen firsthand what that does to the ability to provide services to a population that now totals 1/3 of all California residents. I led the hospitals in the proposal and the development of the first groundbreaking hospital fee program and worked with the legislature and the administration to enact the program that was effective April 1, 2009. That same process was followed for the 3 subsequent renewals of the program that take us through the end of this calendar year. In total, from 2009 through the program ending later this year, the hospital fee has improved access to vital medically necessary services for Medi-Cal patients and the communities where they live by mitigating about $18 billion of the more than $40 billion in losses incurred by hospitals in treating Medi-Cal patients, in treating these individuals, in treating these families, these seniors, and these Californians. In addition, the hospitals have or are scheduled to provide the state general fund with nearly $4.5 billion of funding that is directed towards the cost of children's health care coverage. That means the hospital fee program is largely responsible for financing Medi-Cal and other programs that provide health care coverage to nearly 7 million children in California, year after year after year. The funding has grown to nearly $1 billion a year at current levels. We believe in the importance of protecting coverage for California's children. Protecting the Medi-Cal program is of great importance to hospitals. During past periods of economic downturn, people in California relied heavily on Medi-Cal when they found themselves unemployed and they lost job-based coverage. Unfortunately, that's when the Medi-Cal program is most vulnerable to the diversion of funds for beneficiaries, for patients, for children, for seniors, for the disabled, and for the working poor. We feel strongly that protections need to be in place for ensuring medically necessary services will be available to Californians when they are most in need. Just as the 1115 waiver is the primary financing mechanism for the public hospitals, the fee program is the primary supplemental payment mechanism for the private hospitals. However, public hospitals, as you heard, receive hundreds of millions of dollars from the fee program. We believe the program has been very thoughtfully designed to provide incentives for more coordinated care, and all funding to the hospitals is directly correlated to care provided to Medi-Cal beneficiaries. The money follows the patient, and there are no political calculations that take funding away from Medi-Cal services. We are proud of the program's design, and we believe its integrity should be protected to ensure the money follows the patient into the future. As you heard, CMS has reviewed the program at every pivotal point since its enactment and has approved every version, affirming that the program complies with all federal laws. Now, with many years of experience under our belts, the hospitals felt it was time to find a way to provide greater protections to the Medi-Cal program and its beneficiaries. Renewing the program every couple of years has proven to increase the chances for politics to interfere with health care services for California's most vulnerable residents. Advancing the Medi-Cal Funding and Accountability Act provides those protections we believe are necessary. The Act gives protections for children by ensuring an ongoing stream of revenue is provided to pay for health care coverage. It ensures Medi-Cal beneficiaries will have access to medically necessary care and that the maximum level of federal dollars will be used to protect those services. The Act provides for flexibility to adapt to the changing healthcare environment. The legislature is given the authority to make changes to the program necessary to obtain or maintain federal approval of the fee program. The Act also allows the fee program to right-size. It grows as more federal dollars become available, and it contracts if there are changes that require a smaller program. It easily adapts to new ways of delivering and paying for health care in the Medi-Cal program. The Act was intentionally and carefully crafted to be a complement to the Medi-Cal program, not to work against it. As you heard, a recent final federal rule tests such flexibility. CMS issued a final rule aimed at modernizing Medicaid managed care regulations in a number of areas, including promoting accountability of Medicaid managed care payment rates and strengthening the quality of care and delivery systems. One of the changes required in the final rule is the mandatory phase out of pass-through payments over a 10-year period of time. The hospital fee program supplemental payments for managed care, not fee-for-service, are impacted by this rule. The final rule, however, provides alternatives for continuing these necessary payments. One such pathway, as you heard from Ms. Cantwell, includes the development of minimum fee schedules that allow for uniform dollar or percentage increases in payments to classes of providers, such as hospitals, and for specific services, such as inpatient and outpatient care. I don't want to leave you with the impression, though, that this task will not be a significant effort and highly complex. But given the alternative, I can assure you that the hospitals are motivated to find a solution or solutions, and my guess is the legislature and the administration will be motivated as well to ensure California is maximizing the federal dollars coming to the Medi-Cal program for the state's beneficiaries, and we look forward to working with you to develop those solutions. Now, in building the statutory language that will essentially become the ongoing framework for all future hospital fee programs, we knew a great deal of flexibility would be required. The statute allows for such changes to be implemented by the Department of Healthcare Services to determine the amount of allowable increased payments, taking into account utilization and other factors as they ensure access to high-quality services. This, we believe, provides the department with sufficient flexibility to adapt to the Medicaid managed care rule. And finally, the legislature will continue to have the ability to make changes that further the purposes of the program, including changes necessary to obtain or maintain that federal approval and changes to the fee and payments. The Act removes the existing sunset date so the program can continue uninterrupted while providing the strongest combination of ensuring the state general fund and Medi-Cal beneficiaries are protected, combined with that flexibility needed to respond to a changing delivery system. Thank you, and I'm more than happy to answer any questions you have.